Hi, everyone. Welcome to our last cash seminar for the sort of season. Is that correct? We have one coming in. We have one scheduled in the summer in August, but we're going to take a couple months off of our standard seminars. I'm Deborah Balk. I am the co-director of cash with my colleague Lori Hunter, who may be in the room. Um, so glad to have you all with us today. I'm really delighted that today's seminar is going to be moderated by Melanie Gall, who is the director of the SHIELDES program, which is one of the nation's leading hazards and losses databases. And you can learn more about that from SHIELDES or from CASH. And also, and she's a professor at the Emergency and Hazard Center at ASU. And I got the name wrong yet again, twice in like a minute. So that's really great because I'm not reading it. So anyhow, it's really terrific to see so many people here. We're delighted to have Kai with us as our speaker. I'm going to let Melanie do the introductions. Melanie, thank you for moderating. As always with our seminars, feel free to put comments in the and questions in the chat that Kai can respond to at later on, or Melanie can interrupt as the moderator. We encourage questions as they occur to you, and then we'll have time at the end for discussion as well. So, and I know Kai has said it's still many hours of information just to get this. So. I'm sure there'll be lots of questions and things that he won't get to, but it should whet our appetites. So with that, I turn it over to Melanie for.
Thank you so much, Deborah. So good morning, good afternoon, depending on where you are. I'm excited that Dr. Chen is with us. He's from the Yale School of Public Health. Dr. Chen is an environmental epidemiologist and climate health researcher. He's an associate professor at the Yale School of Public Health and serves as the faculty director of the Yale Center on Climate Change and Health. He's also the president-elect of the GeoHealth section at the American Geophysical Union. And obviously, we'll find out about his research, so I'm not going to keep on talking. We'll find out his research right in his presentation, so why talk about it when he's going to talk about it himself? And I'm really excited to learn about this new dashboard. Super excited. As Deborah said, put your questions in the chat, please. I'll track them. And if you so will, at the end of his presentation, when it's your time for the question, you might as well also just unmute it. So I might just say, so and so, put the question in the chat, and you can just come off mute and ask the question yourself. But I'll, leave that to you. So put the question in the chat. And, without further ado, off to Dr. Kai Chen. Thank you so much for being here.
Thank you, Melanie, for the nice introduction, and thank you, Deborah, for the invitation. It's really a great pleasure today to share some of the work that our group has been doing, in terms trying to really to look at the health effects of all these extreme weather events and how do we actually can quantify them. So let me share my screen. Please let me know if you can see the screen well.
Yes, we
Perfect.
can.
Okay, thank you. So I think for this group, I think we all know climate is getting warmer, and the new record from the EI5 data shows that in the past decades we are seeing the observed surface temperature has surface air temperature has been increased dramatically, especially in the past decade, which has been the warmest decade on record. We've seen the three warmest year in a row, with the past year 2025 was the third warmest year, but only marginally cooler than 2023. And 2024 was the warmest year on record, breaching the 1.5 degrees Celsius kind of target of the Paris Agreement. Although we should be cautious that 1 year passing that 1.5 degrees Celsius warming does not mean that we already passed the 1.5 degrees Celsius, because when we talk about the climate change, it's usually a long-term average. So usually we need a 20-year or even 30-year window to see that average temperature, whether or not that has passed about 1.5 or even the 2 degrees Celsius warming target set by the Paris Agreement. But with this warmer climate, we've seen with our own eyes, like in the past decades, there are more extreme heat events happening. When they occur, they're more frequent and more intense. And sometimes they also occur much earlier, like what we have seen in the West Coast this year, right? And also when the atmosphere get more warmer, it holds more moisture. So in many places, when it rains, it pours. That means more frequent and more intense heavy rainfall can lead into flooding events. But in other regions, unfortunately, there will be increased drought conditions. And as we all have seen, no matter you're in the East Coast, Canada, or even in the West Coast, or even in the South, for example, if you're living recently in Georgia, you've seen that in your own eyes, right? We have Wi-Fi smoke, triggered by the more frequent, extreme Wi-Fi events. There are also other impacts in the ecological system, like acidified ocean, and that could also have like more indirect health impact on on human health. But that will not be the focus of today. So when we think about climate change, in the community of studying climate change health in the past decades, well, there has already been consensus, especially from this last commission on health and climate change, stating that climate change is the biggest global health threat in the 21st century. It impacts our health both directly through all these extreme weather events, but also indirectly through water, air, land, and ecological system. And these changes do not happen alone because they can intertwine with our social dynamic changes, such as population aging, could impact not just our physical health, but also our mental health. So even now, think about the 21st century, we already have the COVID-19 pandemic, but, based on the numbers of what COVID-19 direct and indirect, experts still believe that climate change is still the largest global health threat. But when you talk about something as the biggest, the largest, you must have a number, right? So if I ask you what is the total number of climate change or mortality every year or in the entire 21st century, we don't have that number. People will give you different numbers, right? The WHO have a very conservative number, by the middle of the century, using a 20 years ago analysis, very underestimating the results. And people from different groups are trying to generate new evidence. But so far yet, we don't have a consensus on how big that is. But it doesn't preclude us from piecing out all the evidence saying, wait a minute, these existing evidence already tells us that climate change has already surpassing all the environmental risks that we know. Okay, so the methodology we're going to study how exactly climate change impacts our health is what we call it climate epidemiology. So basically, it's a subcategory of discipline emerging from the environmental epidemiology with more direct combination, collaboration with the climate scientists. So essentially, studying climate epidemiology is a multidisciplinary and study because it requires climate science, environmental science, exposure assessment, epidemiology, and depending on the disease outcome you have, you need your clinical expertise, but also we do need a lot of social scientists, health economics working with us to tease out and find out the impacts on climate change on health. So what we do at the Yale Center on Climate Change Health, especially in my lab, the Climate Health Environment Nexus lab, we primarily focus on three aspects. First of all is the health effects of non-optimal air temperature. The second part is how do we understand the health impacts from all these extreme weather events. And lastly is the epidemiology of air pollution, because air pollution and climate change, they are actually all generated from the same source, fossil fuel, right? So we have emissions. When we burn fossil fuels, you have emissions for carbon dioxide, but also emissions for air pollutants. So from now on, my talk will be primarily focused actually the first two for extreme temperature and extreme weather events, and build on that to introduce why we created this kind of dash tool called XToll. But when we do this kind of analysis to understand the health impacts of climate change, it basically needs a couple of key ingredients. The first one, what's your study population? And what kind of health outcome that is your interest, but also sensitive to climate change. And also, what is the climate-related exposure? And does it change in the past with ongoing climate change, or is it expected to change in the future when we, choose different social economic pathways? And lastly, this is the exposure response function or the essential epidemiological work that we all do in environmental epidemiology to link the exposure and health outcomes. So if we have all that, we can calculate the future climate change related health impacts. But in doing that, the field has dramatically growing in the past decade. We see publications emerging, but there's a lot of challenges still lying ahead. The first thing is that when we do the analysis, obviously, most of the study I introduced here and many others has been doing is based on the low-hanging fruit that, in especially high income or, middle or high income countries where you have this national, surveillance system or vital statistical system or hospitalization or database that can allow you to do this kind of large scale population-based study. But there are a lot of regions that are heavily impacted by climate change. We do not have such high quality health outcome data, especially in low income countries. Even in the US, for example, if you look at the healthcare coverage in rural areas, we don't have much good data in some regions as well. So I think these counts essentially from the health data perspective has already been an essential kind of bottleneck. But also in terms of different exposure we study, there's a huge amount of study looking at heat and air pollution, but not many still emerging on the different type of extreme weather events. So we have a very limited understanding of how these extreme weather events are linked to all the variety health outcomes, both physical and mental. And consequently, I think what it drives us is that the health evidence we see today is a huge, but in a way, it is just a tip of the iceberg, right? So we have huge number of health outcomes are understudied. The link between different variety of climate exposures are not well examined or quantified. And even we have maybe some association studies, we also need to strengthen the evidence to be causal in order to calculate its health burden and to be considered in policy or clinical or public health decision making. So with that, I want to first talk about what we know about temperatures and health. So I'm sure you have seen this type of kind of U-shaped relationship before. So when we look at the temperature and health, so naturally we know that when it's too hot or too cold, it's not comfortable, right? When it's too hot, for example, we have heat stroke. But heat stroke is just a tiny fraction of how heat can actually adversely impact our health. So this curve shows, x-axis is the temperature distribution and y-axis is the relative risk for mortality. What we observe is that, among this U-shaped kind of curve, we see that the temperature, when it doesn't need to go to extremely high, like, for example, 99th percentile to become deadly. Even a 90th percentile or 85th percentile or 80th percentile can also have a significant increased risk for mortality. And by definition, the extreme temperature, 99th percentile, you only have 1% of days that are that high, right? But we have way more days during these kind of moderate heat days. So consequently, when you think about the burden rather than just the relative risk of magnitude, you actually would end up having a much larger burden of mortality from these kind of moderate heat days. So that means, when we think about the temperature impacts, it's not just the extreme heat and extreme cold. Both heat and cold, above or below what we call optimal temperature matters. So that's why sometimes in literature you will see, sometimes we call it the health effects of non-optimal temperature. That is both heat and cold combined. and it goes beyond just the extreme heat and extreme cold. But if we want to dive into why does people die due to the heat or the cold, we can look at it into, for example, hospital mortality or a different, hospitalization or emergency department visits for different hospital diseases. One major disease, our group study is cardiovascular disease. For example, here shows a study that we did using a nationwide health insurance, private health insurance data for young adults. And we know that through many time series studies or case crossover studies that older adults generally are way more vulnerable in terms of heat-related mortality and morbidity. But what is kind of concerning is that if you look at younger adults, actually we see that young adults also have a significant increased risk when it comes to, for example, in the left figure shows the increased risk from heart attack. When temperature goes up, you have increased risk of heart attack. And the right figure shows another study. We look at stroke. So the stroke instance hospitalization rates will increase as well when temperature goes up. When we, combining all the evidence, different causes of disease, and try to answer the question, in the US, how many people die from heat and cold every year? We do have some number. For example, CDC used to estimate, about 600 or 700 people die every year from heat. And recently, we enhanced the surveillance and more better estimation and attribution. Now the estimate goes about more than 1,000 people died every year from heat. But what we know from the epidemiological study is that if you only direct counting the heat-related deaths from ICD codes, that will be largely underestimating, because a lot of the events, in the death certificate may not be directly linked to the heat exposure. For example, in the heart attack example we showed it before, if someone have because heat triggered a heart attack events and they unfortunately died, in the death certificate, the primary cause of death will be just heart attack. And as physician or as someone who examined the death certificate, you would not know what the person has experienced, right? So that's why there's a large underestimation if we only rely on death certificate. So using a nationwide time series analysis that we have studied for all the continents, US counties, what we found is that in the past 20 years, every year there's around about more than 3,000 deaths can be attributed to heat, but more can be attributed to cold, around 45,000. And what's alarming is that if you look at the trend from 2000 to 2020, we see about a 50% increase in heat-related mortality. In the same time, you might expect that we have a warmer climate, so we have less cold days, and since cold in general has much larger burden, wouldn't we expect cold-related mortality burden to be reduced? Well, it turns out, at least in the US for the past 20 years, the cold-related mortality only did not decrease, but slightly increase, right? So you see heat increase dramatically, cold slightly increase. That's why we see in the past 20 years, the overall heat and cold combined mortality burden has actually dramatically increased in the US. And if you dive deeper to see why does cold-related mortality is not declining? Because we know even in some epidemiological studies to show the relative risk has declined. Well, this is because we are not living in a world that only climate is getting warmer. One important social economic factor is the world is also getting older with aging. So on the left panel shows among 800 locations around the world with about 50 countries and regions, we see the temperature change under the future 3 degrees Celsius warming. You can see, that is not a distant future. About in the 260s, under different climate scenarios, the world may already reach that. And by that time, we also know that the population aging will be leading to more and more elderly person. and especially in the low and middle income countries. So if we look at the temperature mortality relationship stratified by different age group, what it turns out is that the older adults group, they turn out to be more vulnerable to both heat and cold. That means with the aging trend, the overall population susceptibility to heat and cold will both increase. That means the exposure response function that we used in the past cannot be directly applied in the future, because in the future, the overall population risk will be higher simply because of aging. Consequently, what we see is that if we combine the global climate models from, we use 18 different climate models, we see that, at different climate scenarios, under 1.5 to 3 degrees Celsius warming targets, the cold-related mortality in general did not decrease. It's actually increased, because the large increase from population aging largely can offset the decrease from the, less cold days. And on the other hand, population aging will amplify the increased heat-related mortality. So in a way, we do not see the cold-related mortality will decline in the future, and we see much larger increase in heat-related mortality. So combining both, aging really substantially amplify the future temperature-related mortality. Now let's switch gears to extreme weather events. So these are just some of the examples that we have seen during the past years, especially the Los Angeles wildfire events happening, and the flooding events in Texas, and some of the big drought events happening in China. Believe it or not, this Poyang Lake is the largest freshwater lake in China. So usually you would not see what's underneath all the towers, right? But now, in 2022, it was so dry, so there's no water there. So what are the consequences of these extreme weather events? Well, these extreme weather events, of course, through a different mechanism, can directly impact our physical and mental health. But more importantly, they can also indirectly impact our health through changing the natural environment, worsening water and air quality, and also change our building infrastructure, the ground space changes, and also can disrupt our society, like leading to power outages, food insecurity, disruption to the clean water and sanitation, interruption to the healthcare delivery, etc. So all these kind of indirect disruption could further lead to impacts on our physical and mental health, leading to substantial increased mortality and morbidity burden. So give you some example of about 3 years ago here in New York City area, we see the sky in New York City become orange. That was because we have large Wi-Fi smoke travel hundreds of miles from Canada. And on that day, New York City was worst air quality in the world. The PM2.5 level, the fine particulate matter level, goes above 150 microgram per cubic meter on that daily average. EPA air quality guideline it's way below that, and usually in New York City we see the PM2.5 level is below 10, right? So consequently, we see during that 3 days, emergency department visits for asthma has substantially increased by more than 40%. So these are the kind of acute respiratory impacts from the wildfire impacts. But we also know that, for regions, especially in the West Coast, and actually in many regions that, even in the East Coast, with long-term, or what we call, repeated exposure to this wildfire smoke, sometimes that doesn't necessarily to be that extremely high level as the orange sky we see in New York City. Even a lower level amount of this wildfire smoke that are repeated, occurring along the year, that could have substantial health impacts. Because what's within this fine particulate matter is the particles, small particles called ultraviolet particles, and it also has a lot of toxic components with enriched oxidative components, pro-inflammatory constituents, sometimes have all these organic pollutants that are carcinogenic, right? So all these we know can trigger a lot of biological responses in our body, such as oxidative stress and inflammation that leads into a variety of cardiovascular health outcomes. We recently did a study looking at the Medicare population. Among all the Medicare population in the US from 2017 to 2022, we see that this kind of long-term Wi-Fi smoke exposure is substantially linked to the increased risk for cardiovascular disease, whether it's heart disease, heart failure, stroke, or cardiac arrhythmia, right? And these also, further analysis also shows us that actually, people with low socioeconomic status, such as eligible to the Medicaid, will actually have much larger risks. And if you look at the map of the Wi-Fi smoke, it tells you a story that it's not just the Western coastal problem, because indeed we have large Wi-Fi smoke, from Canada and from the west, from the southeast as well, right? So indeed, Wi-Fi smoke has become a national problem. So what are the health impacts nationwide in terms of mortality burden? Well, a couple of years ago, we did the first this kind of study, trying to quantify, in each county in the continental US, how many deaths can be attributable to the Wi-Fi smoke. What we found is at that time very alarming, because we already controlled the traditional non-smoke PM2.5. We still observe more than 11,000 deaths that can be attributed to Wi-Fi smoke. And recently, there's more studies actually showing our estimate is very conservative. That could be even 30,000 deaths per year in recent years in the US. And among those, we see cardiovascular disease, mental, and sometimes even endocrine disease can, substantially linked to the Wi-Fi smoke. Now let's switch gear to the extreme precipitation events, drought and flood. When we think about these extreme weather events, the first, typically what we used to consider the larger population that's impacted by this are in low and middle income countries, because understandably, relatively speaking, has the infrastructure, their whole system are not well, resilient or adapted to these situations. So consequently, we see, for example, in this study where we're using the demographic health survey data, we found that both drought and flooding events would lead to a substantial increase in the childhood diarrhea. And we actually have more studies on the different child and maternal health outcomes. Last year we found a study that shows in Africa, drought can also lead to increased risk for infant mortality. And whether it's mild drought or severe drought, we see that increase. And also, we see larger impacts in rural residents, and then some of the differences in different climate zones. I will not go into more detail in this kind of low middle income country studies, because we do have a lot, but I do want to dive into the rationale on this, because we already find these kind of different infant mortality impacts of droughts, and some other people studied on flood in the low and the middle income country. And the general assumption is that in the US is which is one of the top leading economic, typically people have a lot of means to combat drought, or flooding events, especially drought. But there has been some early studies in Medicare showing older adults, long-term drought events can actually lead to a substantial increase in respiratory hospitalization among older adults. So fascinated by these findings, we are wondering, well, in the US, can we find a significant risk for drought on mortality? So we did this, also county level analysis across the continental US from 2007 to 2023, and we look at whether a county in a certain month is exposed to drought, or in this particular study, we also look at what we call the compounding effects when you have both co-occurring drought and wildfire smoke events. So what you see here is that actually the drought, can be substantially linked to increased all-cause or cause-specific mortality such as cardiovascular disease, endocrine disease as well. And we also see, these kind of co-occurring days with both drought and wildfire smoke can have independent additional risks. So if we assume these exposure response functions are causal, we found that every year there can be around like 6,000 deaths due to drought, and more than tens of thousands due to wildfire smoke, and about more than 500 due to their kind of co-occurring added effects. Now let's switch gear to flooding. I do want to mention that we did a study actually earlier, right before the hurricane that impacted North Carolina, leading to 200 hundreds of deaths there. We actually just finished published a study in North Carolina in 2023 to show that the flooding exposure, very few days exposure to flooding, they're not only leading to increased risk for accidental deaths, like people dying from drowning or accidents or hitting by trees, but non-accidental deaths like cardiovascular disease, respiratory illness, even mental health-related mortality can also be linked with flooding exposure, right? So this triggers us to say, hey, can we do this at the national level to see if we can find any evidence or is there any association? So that's why we did a study nationwide looking at the long-term flood exposure, and just found out that actually, nationwide there are about more than 1,000 flood-related deaths per year, and if we zoom out to certain locations, for example, in Texas, we already seeing year by year the number fluctuates, but we do see that actually in some years the flood rate mortality already reached above the 150 mortality, right? So it tells us actually this was published actually in April 2025 before the tragic event happens in Texas. So in a way, although the highlight always focus on the major devastating event, what remains untold is that every year, even before the tragic event, there's already substantial flood-related mortality happening, but we do not talk about it because the data is not there, so not many people know about this. So that really triggers us. We already published these papers, nationwide papers on flood, on heat, on wildfire, on drought. What's use of these papers if we just published and it maybe gets few citations, people, only a handful of people can actually read it, but the information we generate will be lost or not used, and people still has the conception that maybe there's not much flood-related deaths and the tragic event is only some exception events. So triggered by this, and also at the Yale School of Public Health, one mission is really linking science and society, trying to make the scientific findings more useful and communicate better to the public. So driven by this mission, we decided to create a tool, although we do ourselves without any funding support. So one very talented PhD student working with me and create this ArcGIS dashboard. There's a QR code here. You can examine. You can take a look at the QR code, and it will link you to the ArcGIS tool, what we call XToll, the extreme weather tool tracker in the continental US. So what it does is that it shows in each county the kind of relative ranking of the excess mortality due to the combination of different extreme weather events. and the ranking of this county nationwide or within a state. And also you could, click on one of the county, it shows you the numbers of the ranking for each specific event, like heat, cold, wildfire smoke, drought, or flood. And we also try to monetize these impacts by looking at each state. For example, here just shows in New Haven, the Connecticut state, what's the dollar value to the lives lost due to these extreme weather events. So for example, here, right panel shows actually wildfire smoke, despite that, in Connecticut, we relatively speaking are less impacted compared to West Coast and South, but due to the substantial, mortality accounts, the wildfire smoke actually leads to a large substantial economic loss due to the life lost to wildfire smoke. And nationwide, we all know that no one have had this kind of $1 billion disaster events database. But the $1 billion disaster in terms of cost calculation was not based on any of the health cost. This was a physical or property damage or economic cost, but does not include any of the health cost. So we hope this XToll, and we are working on a much nicer version. Hopefully, it's more user friendly. It's easier for you to navigate, and also can download some of the county level report for you. We have already developed a protocol, and we're gonna put it out on our Yale Center Climate Change House website. So stay tuned. With that, I will conclude with a summary that we do see the climate change impacts of full spectrum diseases, from both mental and physical, and we see a lot of social determinants are really intertwined with the climate impacts. And our mission in creating this tool and with many others is really trying to how the health impacts of climate change become visible to not just to the researchers, but to the public. And hopefully it can drive the changes in policy. With that, I would like to thank all the funding support for our lab, and also thank the Chen lab members. As you can see, they are really taking the leadership roles in creating each of the projects. So thank you for listening, and I'm happy to answer any questions.
Dr. Chen, thank you so much for this interesting presentation. And we can already see the interest in the chat. So I'm gonna give Lori Hunter kind of dibs on the first question, because I think you have pretty fundamental questions. So maybe we want to start there, Lori, if you don't mind.
Sure. Absolutely, Kai. Thank you so much for this. You have done so much work, and it's so interesting and so important, and I love the tool. I want to ask if you would be willing to go a little more technical for one of your studies, any of the ones, right? So you did flood exposure and mortality. I can't, maybe one of your latest papers. Could you talk us through the data sources and how you brought them together? In order, just a little bit more methodology. I think people would be really interested in that. And
Yeah,
you've
so
so many papers here, so you get to pick which one you want to do.
yeah. So yeah, one of the reason I didn't put is because each kind of different paper has different data source, and depending on the research question we ask, we use very different methodology.
Right.
So for example, the flood mortality paper, we really try to be as close as we want. So we actually, the lead author, Dr. Lin Zhichu, we created what we call the triple robust approach that combines, the regression modeling, IPW, and the counterfactual approach. We really, as environmental epidemiologists, we try to be very, very conservative. That's our nature. We don't want to exacerbate anything. So that is a unique approach we hope we can apply to others. But for example, the Wi-Fi and mortality paper, that was basically extension version of the difference in difference approach that, basically, in other words, using temporal and spatial fixed effects. In addition, we also control we try to control also the potential interactive spatial temporal kind of trends using an interactive fixed effect model. And also, in another model, when we do the drought, we improve on that because we want to do the compounding. So we actually create a two-stage model. So each kind of paper we show has a slightly different approach and some of the innovative part on it. But I think a general one that if I have to give you an example for everyone to look at what we did. It's a recent Wi-Fi smoke and hospitalization for cardiovascular disease that we published, led by Dr. Sisi Zhang and the group, is that we link the Wi-Fi smoke at it is at a daily 10-kilometer resolution linked to each zip code where we have from the medical population where the residents of these patients. So that paper is a cohort study, and we when you do the exposure assessment, you combine them together, so like at the for example, from start of the follow-up until they have the event or death or end of follow-up, they're kind of exposure. That's the traditional cost per person hazard model you would do. But because anyone deal with Medicare, these 60 million people with all the different life years, is a huge data set. So in that particular paper, we are using what we call the Cox equivalent conditional per sum approach. That has been applied in many air pollution and Medicare studies. So we use that to allow us to do at the zip code level analysis. We run a regression controlling all the different spatial temporal confounding factors that allow us, to look at the Wi-Fi smoke and health. And in doing a lot of these things, you see from my studies when we show the exposure response functions, most of them are nonlinear. So that's the uniqueness of, in a lot of this climate epidemiology study is the exposure and the response are nonlinear. So you need to use different approaches, sometimes like spline approach that non-parametric, or sometimes parametric approaches to control it. Some economists allow to use like different quintiles or other kind of approaches or even categories. So there are different approaches that you can do to control the nonlinear exposure response function. And to get things worse is that usually in environment what we generally found out is it's not only the concurrent exposure matters. The day before or the year before the event also can have kind of lagging effect. So how to control the lag window? Sometimes it's also complex. You need to consider multiple or cumulative lags, and there's different ways called distributed lag model or distributed lag nonlinear model to deal with that. So I think these are the general things that we do when we study these extreme weather events and health outcomes. Hope I answered your question, Laurie. Yeah.
I think I see Lori processing. She might come back with another one.
Yeah, I think I will, but I'll let others have a turn. But I would love to keep pushing. Yeah.
So maybe we can go back kind of early on in your presentation. We have a question related to heat and cold related mortality. Sophia, do you maybe want to come off mute? And maybe also tell me how to correctly pronounce your last name.
Oh, sure. Yes. Sorry. I'm Sophia Arabagis. I'm at CUNY. I'm a postdoc. Thanks for the really interesting talk. I was wondering, and this is just a very specific question, and I'm sure I could go back to the paper and find this, but in the beginning, when you presented the mortality trends for cold and heat in the US from 2000 to 2020, and I was wondering, kind of after that, you reference this age decomposition, and you say, oh, well, maybe this is partially due to an aging population. And I was wondering if you saw that in your 2000 to 2020, if you did the age decomposition for that study in that group and looked at where the excess mortality is actually occurring.
Yeah, I think this is a nice question. I think we certainly did. I need to pull that out to show you. Usually, let's see. Okay, let me share my screen so you can see as well. So that's two. So this is the paper that when we stratify by different age groups, by different So you typically, find here, if you look larger, we see some of the, older adults, they have much larger cold effects as well, and sometimes more heat effects as well. So the 5 to 24 years old, we surprisingly only see a heat effect, not much cold effect. That is not uncommon because if you look at our stroke analysis on young adults, we only see a heat effect. So if typically these kind of young adults was not, considered in many of the studies, but because we really have a huge, all the death certificate in the continent's US, for each country, so we'll be able to, look at a different age group. We actually, obviously this was the final published version, but we also did this kind of large group when you only look at 65 years old versus below. So we see some big differences as well. And I think the general thing, I think we think aging definitely plays a role, but obviously there's many other things could play a role in determining the temporal trends. In this study, that was not the focus to see what's the driving factor. And we actually has another paper, hopefully we can share in a few months, talking about air conditioning role. Yeah.
Great.
Thank you so
Thanks.
much.
Yeah, I was surprised to see it concentrated in that 5 to 24-year-olds. I'm wondering if
Yeah,
that's
that was something,
I was about to say here at ASU, so we had 109 yesterday here in Phoenix. Today it's going to be 106, and you all, I think, are also going to get that heat wave. It's coming, if I saw this correctly. So we see here quite a bit of sports-related youth fatalities. So that could be playing into, this pattern. But so we go from the beginning of our presentation to the end of your presentation because Deborah has a question about excess mortality.
Right. So a little bit like Lori's under the hood a little bit, but I also want to add to Melanie what you just said. I think in a prior study that we did on heat related mortality in the desert Southwest, we found that the highest age group at risk was young adults. And we figured those are largely probably outdoor workers who are unprotected, working in unprotected occupations. And so that they, and probably precarious work as well. So, so that, though we didn't have occupation in the data set in order to evaluate it. So my question though is, Kai, would you mind telling me a little bit more about how you calculate excess mortality? Maybe I missed it, but like in that second to last slide, you show the excess mortality by the different types of disaster. But I don't know what the reference period was for the excess. Like excess mortality tends to be calculated by against some year where the extreme event didn't happen or the disaster didn't happen or some months or whatever. So how did you do that given the wide variation in the, both temporally and spatially? Can you tell us a little bit about that?
Yeah, so the approach generally we take is using what we call attributable burden approach. So basically you have the retro risk, and that tells you at a certain exposure level, what is the retro risk, right? But retro risk does not equal to the burden, right? So you have your exposure, you every day, depending on time scale, for example, let's say heat. The heat, has the exposure response function on each day correspondingly for that temperature on that day, you get a retro risk level, right? So usually we can calculate the attributable fraction on that day, the total number of deaths, how many of that it can be attributable to the heat exposure. Each day it may be small, but then you sum them up on every, all the year long, then you get the total attributable mortality death counts. So that's how we did it for each county and summing up to get, nationwide. So that's how we calculate this. And when we use this approach, because the attributable fraction is calculated by, and basically the the calculation, the retro risk -1 divided by the retro risk. So this is what we consider as the kind of excess mortality fraction. So the excess here means due to this kind of exposure, in a way, is a counterfactual to if there's no such exposure. Most likely, the reference is, for example, in temperature is if you, let's say the reference temperature in different regions could be very different, but let's say that is I'm using degree Celsius. Let's say if 25 degrees Celsius, but if that day is 30 degrees Celsius, then that difference is 30 degrees Celsius versus the 25 degrees Celsius. So that excess is reference to what we call the optimal temperature. And because there's no optimal days or events for smoke or flood, so it's compared to none. So basically, if there's no such flooding, if there's no such drought, if there's no wildfire smoke, that is the reference we're using.
Thank you so much. Alex, do you want to come off mute and ask your question? I saw you typed it in the chat, but I think it's always nicer.
Sure. Yes, of course. I think this is maybe related in Kai. Perhaps we're getting to some of that in the answer to your question, this last question. But I'm more so curious, just as you are kind of approaching these projects, how you're thinking about exposure and exposure for somebody compared to what? So is it compared to some absolute threshold or some or alternatively like some increase above somebody's normal or typical exposure? We can think about this for heat, but it could probably be for other types of exposure as well. But I'm just curious if you played around with these types of relative or absolute measurements, and if they had any big implications for your findings.
Yeah, thanks. That's a great question because everyone studying temperature health effect need to do that journey themselves to find out that, general consensus now is that if you look at this kind of difference, there's a phenomenon called climate acclimatization. Because imagine, for example, here in Connecticut, we are more used to cold because we have a central heating, right? But the same degrees, same temperature, freezing temperature, if it happens in Connecticut versus in Texas, it will have completely different impacts, right? Because people in Texas are not used to that. So similarly, if you think about it, people in Seattle, very hot days versus people in Miami. In Miami, you get used to it. You have a lot of air conditioning in your house, in your workstation, in your work, but Seattle doesn't have. So that's why in 2021, when the Pacific Northwest has the once in a 1,000-year heat wave event, people don't have air conditioning. Many people even don't have electricity fans, right? So that leads to a substantial increase in the heat-related mortality. So that tells us that people adapt to their local climate. So when we compare hundreds of cities within a country, even across multiple, like we have 50 or even more countries results showing that it turns out that people, the optimal temperature is, very close to the most frequent temperature of your local climate. And when we see heat exposure, it's always a relative term. So that's why when we do the multi-country or multi-city studies, you typically need to use this kind of relative scale, like 95 percentile localized temperature versus your the optimal temperature could be let's 80th percentile. So that absolute temperature can be very, very different depending on where you are. Excuse me. So that is the reason why in temperature studies, we typically, if a large national study or even larger, you use the kind of relative scale. But if you are just focused on one city or a small region, I mean, the relative scale doesn't change that much, right? So it doesn't make sense to just use relative scale. So sometimes you can still use the absolute scale. And also depending on your research interest, if the local communities you serve is interested exactly what is the absolute temperature level, so that may be something you can also choose.
Thank you so much. Oh my goodness, you'd like stop answering your question at 11:59. You must have had an eye on the time. So I just want to be conscious of everybody's time, close us out, give you a big thank you, big round of applause for this fascinating and I mean chock full of information presentation. Really, really appreciate it. To repeat Deborah's, I think, early announcement, I think there's another CASH webinar in August So until then, I hope you all have a good summer. See you at various conferences.
Thank you,
And
Melanie. Thank you all.
enjoy the rest of the semester.
Thank you
Take
both.
care.
Thanks, everyone. Thank you.
Thank you.